digestion absorption would like to go over, because that was the part which is not recorded. Pretty much it was the different sections of the intestine, what absorption takes place. So if you look at it, the duodenum, the main things which get reabsorbed there, one thing you have to remember are the divalent ions, calcium, magnesium, iron, right? So any problem with the duodenum, the nutritional deficiencies will be common. Next, in the ileum, what you have to remember is it's a site of reabsorption for bile salts, vitamin B12. So any problem with the ileum can give rise to deficiency of them. Regarding jejunum, what you have to remember, it's a site of maximum reabsorption. It's comparable to your PCT, so that's the site of maximum reabsorption. Then the last part, colon. Okay, so that is comparable to the late distal tubule collecting duct, where it's principally mediated via aldosterone. Okay, and that's under the influence of aldosterone, where there is sodium and water gets reabsorbed and potassium gets secreted. So that was pretty much with what we had covered yesterday. And then diarrhea is where I had spent some time. So if you look at diarrhea, the two main classes which we spent some time was the osmotic diarrhea and secretory diarrhea. So in osmotic, an osmotic particle is not getting absorbed. So because of that, it remains in the lumen, it drags water along with it, and that gives rise to diarrhea. So here the volume is lesser and electrolyte contents is also lesser in osmotic diarrhea. Whereas in secretory diarrhea, for some reason there is secretion of ions. Okay, so what's happening is the chloride channels become open and there is secretion of chloride, which will drag sodium and water along the paracellular routes. So what were the different factors which led to overactivity or opening of these chloride channels? Which was one infection, cholera, where the organism cannot go, but the cholera toxin, what does it do? It goes inside the cell, and what did it do?
Opens the chloride channels.
And how was the mechanism? They do ask you about this. So what did the cholera toxin do? Enlarge one cell. This toxin kept stimulating the alpha GTP, right? And this alpha GTP will continuously activate adenylyl cyclase. So the cholera toxin works by stimulating alpha GTP continuously, which will keep on stimulating adenylyl cyclase. Cyclic AMP levels will keep increasing, and that keeps the chloride channels open. So that's one mechanism. Which was another substance which can cause the same thing, VIP. So any tumor secreting VIP, and one tumor was in the pancreas, of the non-beta cells of pancreas. Gastrin and VIP can be secreted. So here this VIP binds to the receptor, and this receptor leads to activation of adenylyl cyclase and G protein mechanism, and that lead to generation of cyclic AMP, and that kept these chloride channels open. Any intestinal content which can also directly stimulate the chloride channels to be open, which one was that? What in the intestine can cause continuous opening of chloride channels?
Bile acids.
Bile acids, bile salts. So they can keep stimulating the chloride channels to be open. So any condition where the biles do not go back, they remain, bile salts remain in the lumen, can keep stimulating this. So we use the drug cholestyramine. And what does cholestyramine do? It will actually form a complex with bile salts, so it cannot activate these chloride channels. So it can be used for treating diarrhea in excretion of bile salts, but of course it will not correct steatorrhea. So these were the most important things we covered in the last topic. I just went over it because it was not recorded yesterday. Okay, and the cases we have seen. So whenever there is dilatation of the esophagus, which with the narrowing of the lower ends, it gives like a bird beak appearance, correct? So that means what has happened to the lower esophageal sphincter? Food cannot pass. So what has happened to the lower esophageal sphincter? It fails to relax. It's not relaxing because which neurotransmitter generally helps in relaxation? VIP. The myenteric neurons are not secreting the VIP, so lower esophageal sphincter is not relaxing. That leads to accumulation of food in the segment proximal to it and narrowing of the segment because food cannot pass through it, right? So that's the bird beak appearance. And what's the disease called as? Achalasia cardia. Whereas what's the other extreme? Where the lower esophageal sphincter is incontinent. Incontinence of the lower esophageal. It does not close properly, so the fluids etc. can leak. The secretions can leak back into the esophagus, giving rise to metaplasia. Squamous undergoes metaplasia to columnar. Barrett's esophagus. So that could be gastroesophageal reflux disease. In the colon, what was the condition where the myenteric neurons are not working? What was that disease called as? In the colon. In some parts, the myenteric neurons are not working. So this part will be like constricted and food accumulates in this portion above that. What was that called as? Congenital megacolon, otherwise called as Hirschsprung's disease. So because of absence of these myenteric neurons, motility is affected. This part cannot contract. It won't allow the substances to pass, and because of that, the material, fecal material will accumulate, giving rise to a lot of bacterial growth, gas shadows, etc. Intestinal gas shadows are also seen. Peptic gastric ulcer, you know. So those were the important cases we discussed. So go back to the cases. It's also posted on Moodle and try to do them. So I'll just discuss some of the key points, how you do those cases. With that said, now let's move on. We'll start with acid base, which was not revised, right? We did it for this block. So looking at acid base, I'll list out all the different factors. So you will have to tell what is the acid base disturbance in them, okay? Let's do the drugs first. Opiates, salicylates, ethanol poisoning. So all these drugs are toxicity, okay? So overdosage or toxicity of these drugs. Ethanol poisoning, then chronic renal failure, diabetes mellitus, severe case, what can happen? Aldosterone. If aldosterone is high, aldosterone is low, what can happen? You see ECF volume decreases, what do we see? Potassium disturbance in hyperkalemia versus hypokalemia. What can happen? Next, mechanical ventilation, COPD or any other respiratory disease. High altitude, diarrhea. Next is vomiting. Sorry, that line, I don't know, for some reason. After some time it goes away after some time, so just bear with me. Hope you can understand what I've written. So this is vomiting, diarrhea, and too much intake of calcium supplements. Renal tubular acidosis. Any disease, hyperparathyroidism. Okay, let's do it one by one now. So opiate toxicity, what are the opiates? What are the three drugs? Analgesics, what are they?
Codeine, heroin.
MHC, codeine. Morphine, heroin, codeine. So what do they do to what's their action? What do they do to the respiratory center?
Because respiratory depression.
Suppression, giving rise to respiratory acidosis. Salicylates have two actions in an acute condition. Acute means immediately, say within 2 hours. So within 2 hours, what's the action of salicylate? What does it do? It stimulates the respiratory center. Good. So that's why it causes respiratory alkalosis, because person starts hyperventilating. But after say a couple of hours or days, then what can it do? What's the late effect of salicylate? Aspirin, we are talking about aspirin toxicity, salicylate toxicity. So after several hours, it can induce an anaerobic condition in the body. So then what's going to happen? Because of this anaerobic medium, it will lead to generation of lactic acids, acidosis. So what's the late effect of salicylates? Metabolic acidosis. So read the question carefully, whether I'm telling within 2 hours or after several hours and days. Immediately it gives rise to respiratory alkalosis. Late effect would be metabolic acidosis. Chronic renal failure, if the kidney cannot work, what will it give rise to? What's the main role of kidney for acid base? It helps in excretion of H+. So if there's renal damage, H+ is not excreted. So what will it give rise to? Metabolic acidosis. Diabetes mellitus, insulin problems, too much release of free fatty acids, which can get converted to ketone body. So it gives rise to diabetic ketoacidosis, which is an example for metabolic acidosis.
Dr. Prashna,
yes?
sorry. Did you mention ethanol already?
Ethanol, no. Sorry, okay, this one I didn't do it. I'll come back to it.
Okay,
so,
sorry. I just didn't know if I missed it.
Because thank you for reminding. I thought these lines, I'm not sure why I'm getting these lines. So yeah, in methanol, ethanol poisoning, alcohol poisoning, they generate acids, formic acid, oxalic acid. So what does that give rise to? Metabolic acidosis. So thank you. Yeah, I missed that. So it is metabolic acidosis. Now coming to aldosterone, what's its role in acid? Does it have a direct role for acid? What's the main action of aldosterone? Form ENaC, reabsorbs sodium and water. It mainly excretes potassium. But because it excretes potassium, what does the eye cell try to do? Get in some potassium. So in that process, what does aldosterone do? Excrete H+. So aldosterone does not have a direct role on H+, but because it excretes potassium, the eye cell excretes H+, to correct that. So it excretes H+ indirectly. That's how you have to remember. So if aldosterone is high, what's the syndrome? What's the disease where aldosterone is high? What's that called? Conn's syndrome. So what's going to happen? What type of acid base do we get if aldosterone is high?
Alkalosis.
Good. Too much of H+ is excreted, so metabolic alkalosis. If aldosterone is less, say in Addison's, H+ is not excreted, so what will that give rise to? Metabolic
Acidosis.
Vomiting. From the top, what do we lose?
Acid.
Good. There's loss of H+. So what will that give rise to? Metabolic
Alkalosis.
Now what happens when the ECF volume contracts? Your body tries to compensate. So which mechanism gets activated when ECF volume blood pressure drops? RAS gets activated. So what's going to happen to aldosterone and angiotensin 2?
Increase.
Both will increase. And what's the role of angiotensin 2 on acid? It stimulates which pump?
Sodium acid exchanger in the PCT.
Good, sodium acid exchanger, correct? So they are all in the same axis, so they have to do the same thing. Okay, so if aldosterone is excreting H+, that's how you remember that angiotensin 2 also excretes H+. Okay, so if ECF volume decreases, since both of them are increasing, acid excretion increases. So what will this give rise to? Metabolic in ECF volume contraction. Both aldosterone and angiotensin 2 are increasing. So they both excrete acid. So too much acid is
alkalosis.
Metabolic alkalosis. Good. Now coming to potassium. Whenever there is a potassium disturbance, the eye cell tries to compensate it. So that's what you have to remember. So in hyperkalemia, you have too much potassium. So what will the eye cell try to do? Excrete potassium. In that process, what will happen to H plus?
It'd be excreted as well.
No, they are opposite.
It shifts into it causes acidosis, right?
Correct. Because see, this H plus potassium pump is counter transporter. Okay. So when it's trying to excrete potassium, H plus goes in the opposite direction. It's a counter exchanger, not co-transporter. Okay. So when there is hyperkalemia, you start with that. The eye cell tries to get rid of potassium, but in that process, H plus will enter. So that gives rise to metabolic acidosis. In hypokalemia, there what happens? Potassium is less. So now what the pump tries to do? Eye cell pump. In it will try to get in potassium. In hypokalemia, the pump tries to get in potassium, but in that process, what gets excreted? H plus. So what will this give rise to? Metabolic alkalosis. So on the exam, the spreadsheet, quickly write down and try to find out. Okay. So hyperkalemia causes metabolic acidosis. Hypokalemia causes metabolic alkalosis. Renal tubular acidosis, the PCT and eye cell pumps are not working. So the name is self-explanatory, tubular acidosis. So it has to give rise to metabolic acidosis.
Dr. Praj, I have a quick question.
Sure. Yes,
is renal tubular acidosis normal anion gap or high anion gap?
That depends. So when I'm doing anion gap, I'll explain it. Because if you look at bicarbonate pumps, there are two different pumps which will be affected. So after I erase this, I will explain that. Okay? Okay. Mechanical ventilation. What's going to happen? Mechanical ventilation, we are giving high pressure oxygen to the patient. More and more of oxygen is getting into the lungs under high pressure. So obviously what should happen to CO2? Decrease. So what will that give rise to? Respiratory alkalosis. COPD, any respiratory disease. If the lungs are not working, there's carbon dioxide retention, hypercapnia, which gives rise to respiratory acidosis. High altitude. So in high altitude, to compensate for the oxygen, how are we breathing?
More.
Hyperventilation.
Yeah.
So carbon dioxide is eliminated. Respiratory alkalosis. Diarrhea, bottom, what do we lose? Bicarbonate. So even yesterday I told you, in diarrhea, the intestinal cells excrete bicarbonate. Okay. And when they excrete bicarbonate, remember this is negative, so to compensate for that, potassium also gets excreted, giving rise to hypokalemia as well. But if you are asking about acid base, we are excreting bottom base. So what will diarrhea give rise to? Metabolic
acidosis.
Acidosis. Good. Calcium supplements. What's the connection? If we take too much calcium, we'll have too much calcium in our blood. So whenever positive ions are more, your body will try to compensate for them. So what will it favor? Absorption of
bicarbonate.
So calcium intake, excessive calcium supplements can favor bicarbonate reabsorption, giving rise to metabolic alkalosis. So if you forget this, remember about the milk alkali syndrome. Milk is associated with alkaline pH. Why? Because calcium favors bicarbonate. Hope this one I will do. Hyperparathyroidism I will do. Rest all I've covered. So let's go back to hyperparathyroidism. What's the connection of hyperparathyroidism with acid base? Main action of PTH is on the calcium, correct? But which second messenger does calcium use? PTH use? Cyclic AMP. So what happened in hyperparathyroidism? PTH increased, cyclic AMP increased. So what's its role? Remember I had mentioned this. If you look at the proximal tubular acid pump, it's the sodium hydrogen ion exchanger. You have to remember this is dealing with sodium reabsorption. So sodium has to enter, bicarbonate has to leave. So which substance stimulated the pump? Angiotensin 2. But what will high levels of cyclic AMP do? It will shut down this pump. So in any disease where cyclic AMP increases, the pump cannot work. So what will it give rise to? Metabolic
acidosis.
The pump cannot work, H plus cannot get excreted. So what will it give rise to? metabolic
Acidosis.
So if you're doing questions, you'll see some questions where they're talking about PTH, but they're also giving that pH is acidic, so don't get confused. That's because of the effect of cyclic AMP. Okay. Now what is plasma anion gap? When we are doing all this, just for completion's sake, in myasthenia gravis, poliomyelitis, Guillain-Barré, what can happen? In all this, the respiratory muscle movement is less. So what will it give rise to? If the respiratory muscles cannot move, it will give rise to respiratory
Acidosis.
acidosis. Good. Next, stimulation, diffusion. Okay. So these are some of the examples. So in exams, that's how you should know. I will give you something. You should be able to tell what's that acid base and then speak about compensation. So after we do compensation, I'll give you examples of questions where everything you will be able to tell. Okay. So next what we'll do is plasma anion gap. So what's the formula for plasma anion gap? The positive minus some of the negative ions, which are the bicarbonate and chloride. So in ketoacidosis, lactic acidosis, methanol, ethanol poisoning, so all these, what's happening? There's accumulation of H plus, and when H plus accumulates, it overconsumes bicarbonate. So what happens to resultant bicarbonate? They get depleted, exhausted. So this had nothing to do with the bicarbonate chloride exchanger. The bicarbonate decreased independently. And why did it decrease? Because acid was higher, resultant bicarbonate levels were less. Was it at the expense of chloride? No, it was just by itself bicarbonate was less. And if this number is less, what will happen to the anion gap?
Increase.
It will
Increases.
increase. So it's called as an anion gap metabolic acidosis. Now, when it comes to renal tubular acidosis, it's a bit tricky because there are two types of renal tubular acidosis. This is going back to Uzair's question. So in renal tubular acidosis, the two sites where the pump handles acid can get affected. So which are the two sites which get affected? Proximal convoluted
and ISO.
and ISA. So remember the proximal, it is sodium hydrogen ion exchanger, and here it is the hydrogen potassium ATPase pump. And what's the bicarbonate pump on the basolateral surface? In the PCT, it's the sodium 3-bicarbonate co-transporter. You remember this? Whereas in the I cell, it is the bicarbonate chloride exchanger. So it will depend on which type of renal tubular acidosis is it. If it is renal tubular acidosis where the PCT is affected, so then acid cannot be excreted. It will give rise to metabolic acidosis. And what will happen? This won't work. So what has happened? Bicarbonate alone has decreased. So only bicarbonate decreases. Therefore, what will happen to the anion gap? Increases. Why? Because only bicarbonate decreased. There was nothing to do with chloride. Only bicarbonate decreased. So in this case, in this type of renal tubular acidosis, anion gap will increase. But if you go to the other type where I cell pump is not working, so that will give rise to metabolic acidosis. But because this pump does not work, this also won't work. So here it is bicarbonate chloride exchanger, correct? So what will happen here? Bicarbonate will decrease, but chloride will increase. So this is affecting the chloride exchanger. So any disease where the bicarbonate chloride exchanger has been affected, bicarbonate will decrease and chloride will increase. So it will be sodium minus, bicarbonate will decrease, but chloride at the same time has increased. So this number will not change. So that means the anion gap stays normal. Okay, so that's why in renal tubular acidosis, it will depend on which site is affected. If PCT is affected, anion gap will increase. If I cell is affected, anion gap remains normal. Okay. Next, in diarrhea, what will happen to the anion gap? So in diarrhea, even yesterday I told you, the intestinal cells along with mucus will excrete bicarbonate. So this bicarbonate was excreted across the bicarbonate chloride exchanger. So since you are losing the base, it is metabolic acidosis, where bicarbonate decreases, but what will happen to chloride? Bicarbonate is excreted, but chloride will increase. And whenever you see bicarbonate decreasing, chloride increasing, what will happen to the anion gap? It will be normal. So we call it as non-anion gap hyperchloremic metabolic acidosis. Okay, so there are two examples actually for this. One is diarrhea and the other one is renal tubular acidosis affecting the eye cell. At that time it was too much to tell all at once, so we didn't talk in detail about the renal tubular acidosis. In fact, they will do about the different types. But in short, for physio, you remember in renal tubular acidosis, the two sites which angle acid gets affected, either PCT or eye cell. So depending on which site is affected, anion gap can increase, but if the eye cell is affected, the anion gap stays normal. Okay, so that's the significance of anion gap. So conditions where it increases, where it does not change, you have to remember. So after we do that, let's talk about the compensatory mechanism. So first let's apply the Henderson equation. In metabolic acidosis, acid is high. So as a result of that, what happened to bicarbonate? It got consumed. So in acidosis, the base bicarbonate should always be less. And what is Henderson equation stating? pH is directly proportional to log of bicarbonate over partial pressure of CO2. You can read it, no? That line, sometimes I think the pen something, after I updated the program, it puts some lines sometimes. I'm trying my best to avoid it. But this is not striking. Please, you can read it, right?
Yeah.
Okay.
Yes, it's fine.
Okay, thank you. Okay, so tell me, in metabolic acidosis, bicarbonate is less. So according to Henderson equation, if the pH has to come back to normal, what should happen to CO2? Decrease as well. So that means the lungs have to compensate, right? For CO2 means it has to be the lungs. So how did it compensate? When arterial H plus increases, this is in the artery, arterial blood, can it cross the blood-brain barrier?
No.
Arterial H plus cannot cross the blood-brain barrier. So that should help you remember which chemoreceptors it activates.
Peripheral.
Peripheral. It cannot cross the brain, no? So it does not reach the brain. So it has to activate peripheral chemoreceptor, which will then activate your respiratory center. And following activation of respiratory center, the person begins to hyperventilate. And as a result of that, CO2 will decrease and pH goes back to normal. Okay. So any condition of metabolic acidosis, because of compensation, the person will start hyperventilating. What's metabolic alkalosis? Here H plus is less, bicarbonate is more. Correct? So according to Henderson, if bicarbonate has increased, what should happen to carbon dioxide as well? It should go in the same direction, it should increase to get the pH back to normal. So how did this happen? When H plus decreases, then what will happen to the stimulus for the peripheral chemoreceptors? It's not stimulated. As a result of that, the center is not stimulated. So how will the person breathe? Hypoventilation. So as a result of hypoventilation, this carbon dioxide retention, pH comes back to normal. So on exams, write down the Henderson equation. So that will help you to remember which direction the compensation should happen. So when we do those number problems, if you diagnose the disease as metabolic, to comment on compensation, which value we should look? So for metabolic disease,
Bicarbonate.
no.
CO2.
Look at the equation here. If it's a metabolic problem, there is a problem with bicarbonate. So who is going to compensate? CO2. You're right. For metabolic, both the lungs and the kidney can help. But which is the first organ to compensate?
The respiratory system.
The respiratory system, correct? So that's why if you identify the disease to be metabolic, to comment on compensation, which value should we look for? CO2. Okay, metabolic is a problem with bicarbonate. So for compensation in Henderson equation, you have to look at CO2 value. Is CO2 40? or has it changed? If CO2 is 40, compensation has not yet happened. If it has changed, then it has started compensating. Now let's go to rest. So metabolic, both lungs and kidney can work, but to comment on compensation, if it's a metabolic disease which has affected bicarbonate, so then which value should you look for to comment on compensation? Only CO2 value, okay, because lungs compensates first. Now let's go to respiratory acidosis. So in respiratory acidosis, what happened? CO2 had increased, correct? And if CO2 increases, according to Henderson, if pH has to remain or come back to normal, what should happen to bicarbonate? Increase as well. And who's going to compensate? Kidney. So if your disease is respiratory, to comment on compensation, you have to look at bicarbonate levels. So you have to see if it's on the blood buffer line or not. So if it's on the blood buffer line, it has to be between 18 to 28 milliequivalents per liter. Okay, so if the value is between this, that means the compensation was not significant. It's on the blood buffer line. But if it has compensated, it should go way below 18 or above 28. It has to move away from the blood buffer line. In respiratory alkalosis, now what happened? CO2 is less, and according to Henderson equation, if CO2 has decreased, the only organ which can compensate in respiratory is the kidney. Lungs are defective, they cannot compensate. And how will the kidney compensate? What will it do to bicarbonate?
Decrease.
It will decrease. So any change in one variable, the bicarbonate should, both CO2 and bicarbonate should increase, or in alkalosis, CO2 has decreased, so bicarbonate should decrease. So now let's see, in the lungs we saw how it works. The arterial H plus stimulates peripheral chemoreceptors and causes the change. Now in kidney, what's the compensation in the kidney? So if you look at renal system, only two sites which handle acid will be the proximal tubule and the late distal tubule collecting duct, I cells. Correct? So in the proximal, the acid pump is sodium hydrogen ion exchanger. But now we also have to know from where did we get this H plus? Carbon dioxide reacting with water and hydrase forms carbonic acid, which generates H plus and bicarb. So for every H plus excreted, what's the fate of bicarbonate? It will follow the sodium 3-bicarbonate co-transporter. So that's the reason for every one sodium 3-bicarbonate is following. So again, which is the site of maximum bicarbonate reabsorption? Your answer should be
PCT.
PCT. Okay, everything is PCT. Now in the I cell, what happens? The acid pump is potassium H plus ATP is pumped. It was the same reaction of CO2 with water and hydrase generates carbonic acid, which dissociates into H plus and bicarb to first generate carbonic acid. Okay. Now here, how did bicarbonate enter the blood? Here it was across the bicarbonate chloride exchanger. Okay. Now if there is acidosis, what will these cells try to do? What will the pumps try to do? Wants to correct it, correct? If it's an acidic pH, they want to correct it. So what will happen to these pump activity? It gets activated. So there's more and more of H plus being excreted. So if lots of H plus is excreted, it can cause damage to the cells, correct? Does it happen? No. Why? Like the blood,
Lumen buffer.
there are buffers in the lumen as well, which is ammonia and phosphate buffers. Okay, so because of that, in acidosis, when the cells are trying to excrete H plus, it will react with NH3. So what will happen to ammonium formation?
Increases.
Will increase, and H plus can react with phosphate. So the acid component is H2PO4 and base component is HPO4. So there's lots of H2PO4 formed. So what will happen to the H2PO4 HPO4 ratio? It will increase. What's another thing which is happening? What will happen to filtered bicarbonate? In acidosis, do you want the filtered bicarbonate to get excreted or conserved?
Zero.
You want it to get conserved, correct? And how is it getting conserved? This bicarbonate will react with H plus, and what will it regenerate? bicarbonate HCO3, which is filtered, reacts with H plus, add it up. What is regenerated? Carbonic acid, and that will dissociate into carbon dioxide and water because anhydrase is present even in the lumen. And once carbon dioxide is regenerated, it will get recycled back. So in acidosis, what will happen to filtered bicarbonate? We take it back. How? Bicarbonate will react with some of the H plus and it will regenerate carbon dioxide and water, and it is recycled back as CO2. So all these mechanisms gets enhanced. Same thing in the distal tubule, acid is excreted, bicarbonate is conserved. So what are the urinary changes? If they ask you what are the renal consequences, they are asking you what are the urinary changes because of renal compensation. So what will happen to the urinary H plus excretion?
Will increase.
Increase. What will happen to the urinary pH? In acidosis, if urine has lots of H plus, that means what happens to the urinary pH?
Decreases.
Decreases.
What will happen to ammonium formation?
Increase.
Increase.
Hydrogen, dihydrogen phosphate will increase. So what will happen to H2PO4, HPO4 ratio? Increases.
Increase.
What will happen to bicarbonate in the urine? It's going back into the cell. So what will happen to bicarbonate in the urine?
Decreases excretion.
It decreases excretion. So the bicarbonate excretion, remember this is urine. So bicarbonate excretion in the urine will be less. So that's in acidosis. In alkalosis, what should happen?
The urine acidity
Decrease
decreases,
pH.
which will lead to a low NH formation.
Correct. So in alkalosis, you want to conserve the acid. So what will happen to all the pump activity? It will shut
It
down.
stops.
It will stop. So what are the renal consequences in alkalosis? Since H plus is being not excreted, so what will happen to the urinary H plus?
Increase. No, decrease, sorry.
H plus is not excreted. So this is urine I'm asking. So urinary H plus will decrease. That's why pH will be alkaline.
Increase.
What will happen to ammonium formation if the pumps are not working?
Decreases.
Ammonium formation decreases. What will happen to dihydrogen phosphate hydrogen phosphate ratio?
Decreases.
Decrease.
Decreases. Now bicarbonate, what will happen to the filtered bicarbonate? If the pumps are not working, your filtered bicarbonate does not get H plus to react. So it cannot recycle back. Instead this bicarbonate gets excreted. So what will happen to
So
bicarbonate?
increase. The excretion will increase.
Excretion will increase. So that is it. Compensation. But in questions, how do you have to know this? If I am giving you a case of diabetic ketoacidosis, patient has Kussmaul's breathing, high blood sugar, acetone odor, everything, you know it's ketoacidosis. Ketoacidosis is what? Example for?
Metabolic acidosis.
Metabolic acidosis. So then they will ask you about, they will give it in a table type of questions. You have to be aware because you're testing multiple concepts. So generally those questions are quite popular. So you have to comment on what happens to arterial H plus, pH, then what will happen to the anion gap, what will happen to ammonium excretion, dihydrogen phosphate hydrogen phosphate ratio. They might also ask you about, say, urinary bicarbonate levels, what's going to happen. So ketoacidosis is metabolic. So what happens to arterial H plus? Yes?
Increase.
Increase.
pH,
Decrease.
Decreases.
acidic, anion gap.
Increase.
Increase.
Tell me one answer. Yeah, I think Erika is correct. What happens to the anion gap here? Because it's
Increase.
it will increase. Correct? Because why? Only bicarbonate decreased here. So anion gap should increase. Ammonium formation,
Increase.
dihydrogen phosphate ratio.
Increase.
It's acidosis. So you're trying to conserve bicarbonate. So what will happen to urinary bicarbonate?
Decreases.
Decrease. Aspirin or salicylate toxicity. Okay, so if it's aspirin salicylate toxicity, let's say if person is coming after several hours. Yes, Janay?
Why does why does the NH4 increase in diabetic ketoacidosis? Is this talking about the urine or the blood?
Where is that ammonia? Ammonia is not in the blood. Ammonia is in the lumen.
Okay.
Okay, yeah, this refers to urinary ammonia because ammonia buffers are in the lumen, right? So when acid is excreted, it will react with NH3 to form NH4. So if they are asking ammonia, even if they don't give urine, you have to assume it's talking about the luminal surface, not the blood.
Okay. And the same thing for the H2PO4.
Yeah, because phosphate and ammonia buffers are found in the lumen.
Okay.
They are not present in the blood significantly. So then these must refer to changes in urine. So sometimes they mention it is urine, but sometimes you have to assume that they are talking about urine. Okay? Yeah, that's a good question. Yeah. So I saw questions where they don't refer it as urine, but you have to assume that it is in the urine. Now salicylate toxicity after several hours. After several hours means what are they coming with?
Metabolic acidosis.
Metabolic acidosis. So again, what will happen to H plus?
Increase.
pH?
Decrease.
Now here again accumulation of acids only. So bicarbonate gets used up, not at the expense of chloride. So what will happen to the anion gap?
Increase it.
It should increase. Why? Because only bicarbonate is decreasing, not at the expense of chloride. Urine, so because of that, all the buffering activity in the kidney will increase. So what will happen to ammonium formation?
Increase it.
And H2PO4 ratio will increase. Urinary bicarbonate excretion will decrease. Okay. In high altitude, there was a nice question, but they're asking you so many things regarding high altitude, correct? So what happens if a person goes to high altitude? They're asking you about carbon dioxide levels, partial pressure of CO2, pH, 2,3 dpg, erythropoietin, bicarbonate levels in the blood. Then they're asking you about hemoglobin oxygen affinity. Okay, so tell me about high altitude. As a person goes to high altitude, there's a drop in oxygen. So when it drops below 60, what's the first change? It stimulates what?
Respiratory.
First organ to compensate will be the lungs. So it stimulates the lungs, and how will the person breathe?
Hyperventilating.
So because of that, carbon dioxide will decrease, pH will increase. So that's why it causes respiratory alkalosis. So because of the hypoxia, what will happen in the kidney? The kidney tries to compensate for the hypoxia. So what will happen to erythropoietin secretion?
It will increase.
Increase. If RBCs increase, what should happen to 2,3 dpg as well? Increase, which will bind to the beta chain of hemoglobin. So what is happening to the affinity? It's increasing or decreasing?
Decreasing.
Decreasing, because whenever 2,3 dpg increases, it will go and bind to beta chain and displace oxygen. The curve shifts to the right. It's releasing oxygen to the tissues. And if oxygen is released to the tissues, what's happening to affinity of hemoglobin for oxygen? Decreases. Bicarbonate levels. So that is based on compensation. So here what happened to CO2? Decreased. So how should the kidney compensate? What should happen to bicarbonate levels?
Excretion.
So bicarbonate levels will decrease. Henderson equation. CO2 has decreased. So how will the kidney compensate? By decreasing bicarbonate. So that's a challenge. Even your shelf questions, they are okay. It's only thing that they ask you to integrate so many things. So that's the reason you have to do questions. I'm sure we are doing questions now. You realize concept understanding is 50%, application is another 50%. So you have to do as many questions as possible. So the shelf, no, it might look very challenging, but at the end of it, on the block exam, say if you got 78, that's your grade, correct? But on the shelf, it's a scaling format. The highest score is taken like highest score in the class, that's 70th percentile, right? So that's taken as 100%. Then whatever extra what you get above or below, if you have got less than that, then you will be graded accordingly. Okay, for example, say the 10th percentile was something with the reference score. Okay, and based on that, if your class is not able to get that 10th percentile, whatever deficit was there gets added up. So what in short I'm trying to tell you is, on the shelf, because of this curving, you will be at the level you went into the shelf. Say you went with 78, because some grades are added based on that curve, you might go up or down by say 1 or 2 points, not much. So you will be in the end around this grade when you went into the shelf. And sometimes if the questions are very challenging, say out of 125, they may grade only 120. That means it was out of syllabus, it was not required for you at that point. So sometimes they would even grade those questions. So even if it looks difficult, don't panic, because in the end, because of this curving system, whatever score you get will be around that going into the shelf. Plus or minus 1 or 2 points, that's beyond our control. So that's the reason going into the shelf with a good average is important. So on this block, try to get as much as you can so that you're going into the shelf with the safe average. Okay, so that's how. Now these are the integrating type of questions which they generally ask. So that's why you have to be aware of how to do these questions. So that was it. When you come back, we'll do the Davenport diagram, some number problems, and I'll move on to endocrine. So it's 8:15. Come back after a 10-minute break. Okay, thank you.
Thank you.
Thank you. Dr. Krajna,
Yes,
for the last example that you did for hyperventilation,
correct.
is EPO increasing because the kidney needs to compensate for the drop in CO2?
Drop in oxygen. Because what's the stimulus for erythropoietin? Hypoxia. Okay, so
Right.
whenever there's hypoxia, your kidney senses there's no enough oxygen. So who can carry oxygen? Hemoglobin, right? So kidney tries to produce that helper, that's RBCs.
Okay, thank you.
Whereas renin-angiotensin is blood pressure, related to blood pressure. So what's the stimulus for renin-angiotensin? Ischemia. Ischemia is decreased blood flow, right? Can cause ischemia. So because that's how you remember, kidneys can, so the kidneys can secrete renin, and the kidneys can also secrete erythropoietin, correct? But erythropoietin is to do with RBCs. So what's the stimulus for erythropoietin? When there is less oxygen, hypoxia, so that will tell the kidneys to produce more RBCs so that it can carry that oxygen, so that releases erythropoietin. But when the blood pressure drops, blood flow will be less. So that will cause ischemic changes in the kidney. So that will tell the kidney there's not enough blood flow. So do something to increase the blood flow, blood pressure. So that's what causes release of renin. Okay, so here in high altitude, it was because of hypoxia.
Okay, thank you.
Yeah. Okay, everyone, let's get back.
Dr. Prajna,
Yes, yes, me.
is this session getting recorded?
Yeah, this session is getting recorded.
Cool, thank you.
So after this, I'll stop this and put another recording for the next 2 hours, okay? Now the recording is still on. Now since you asked, I'll just check again. Yeah, it's getting recorded. Yes.
Thank you.
Okay, no worries. Okay, next let's do the Davenport diagram, where the x-axis represents pH and the y-axis represents bicarbonate levels. Okay, millimoles per liter or milliequivalents per liter. So if you have normal point, the normal point should correspond to a pH of how much? What's a neutral pH?
7.4.
7.4. And at this normal point, how much is the bicarbonated?
24.
40.
24. 24 is a bicarbonate. 40, what you're telling me, is the carbon dioxide. And partial pressure of carbon dioxide is at 40 millimeter mercury. So at normal point N, pH corresponds to 7.4, bicarbonate corresponds to 24, and partial pressure of carbon dioxide corresponds to 40. Then you also have a blood buffer line which runs like this, and the blood buffer line corresponds to a bicarbonate levels of 18 to how much?
28.
28 millimoles per liter. Sorry, I don't know the lines. Okay, so this
Did you
one,
try to disconnect it and connect it again?
I'll shut off the computer then. During the break, I'll try to do it, okay?
Okay.
Disconnect, just now I tried, it didn't work. So during the break, I'll have to shut off the whole system and start again. Sometimes then it works. So let me see during the other break, okay? So for now, let's look at, if one thing is rectified, there will be another problem. So that's life, right? You learn to deal with it. Just go with the flow. Okay, so let's start with normal point here. Now, if you have points which are on the blood buffer line, you have points A, B, and then you have point C and D. So any point on the line has to be an acute change. That is, in short, for exams, that's how you remember. If any point is on the line, it's an acute change. So let's see points C and D. They are on the carbon dioxide line 40. So that tells you that carbon dioxide is not the problem there. So any points on carbon dioxide 40 line has to be what disturbance?
Metabolic.
Metabolic.
It has to be metabolic. So C would be acute, because the CO2 should have compensated. It's not yet compensated. So point C would be acute, otherwise called as uncompensated what? Metabolic?
Alkalosis.
Acidosis.
No, the pH is alkaline there, right? So it is metabolic
Oh yeah, I'm sorry.
alkalosis, because bicarbonate has increased at that point. D would be acute or uncompensated metabolic
Acidosis.
acidosis. Therefore, if those are metabolic, points A and B has to be respiratory, where the bicarbonate was not the main problem. It was between 18 to 28, which is a minimal change. But at point A, the CO2 line moved significantly upward, and at point B, the CO2 line moved significantly downward. So carbon dioxide was a major change. So what will you call point A as? Acute, uncompensated what?
Respiratory acidosis.
Respiratory acidosis. B would be acute or uncompensated respiratory alkalosis. Okay. So that's about the acute points. Now, where acute or uncompensated. Now what if the points are in between the quadrant? So if you have points in between. So whenever it's in between, that's a straight giveaway that compensation started, but it did not come back to 7.4. So it's in between. So it has to be partially
Partially.
compensated. So it has to be partially compensated. So now you have to decide partially compensated what. So let's see A, B, C, D, E, F, G and H. So what is point E? It's closest to which primary disturbance?
Respiratory alkalosis.
Point
Oh,
E.
Acidosis.
So partially compensated respiratory acidosis. Point F is closest to which primary disturbance?
Metabolic alkalosis.
So partially compensated metabolic alkalosis. G is closest to which primary disturbance?
Partially respiratory alkalosis.
So it's closest to this point. No? That means this point has moved. So partially compensated respiratory alkalosis, and therefore this would be partially compensated metabolic acidosis because it's closest to this primary disturbance. So as the points move, finally they may reach points X and Y. So what do points X and Y mean? They have not gone back to normal point. So then you can't call it as normal point. But only thing which happened at X and Y is pH came back to 7.4. But at point X, the carbon dioxide is still less. Sorry, at point Y, carbon dioxide is still less. Bicarbonate is still less. At point X, carbon dioxide is still high and bicarbonate is also still high. So that cannot be normal point. So that's why we will call it as completely compensated. But there are two possibilities. Tell me point X. That means the two primary disturbances reached complete compensation. What are they?
Metabolic alkalosis or respiratory acidosis.
Metabolic alkalosis or completely compensated respiratory acidosis. Therefore, point Y would be the two primary disturbances reached complete compensation. So what are they? Completely compensated.
Respiratory alkalosis and metabolic acidosis.
Or completely compensated metabolic acidosis. Good. So whatever primary disturbance we saw, it is either metabolic or respiratory. They only fall in the upper and lower quadrant of the X. So this is an X shape, right? So it will be in the upper or lower quadrant. Why? Because they are following Henderson equation. Take any point in the upper quadrant. What has happened to both carbon dioxide and bicarbonate? If it's in the upper quadrant, both have increased. If it's in this lower quadrant, what has happened to bicarbonate? You can check it. Bicarbonate and carbon dioxide both have decreased. And because they are following Henderson equation, it should be a pure acid-base disturbance. Now what will happen if you have points S and T, which are in the side quadrants? So let's see what happened at point S. Carbon dioxide line moved up, but bicarbonate moved down. So these arrows are not in the same direction. So whenever they are not in the same direction, you blindly tell that is mixed.
Mixed.
Mixed what? What has happened to pH here?
Acidosis.
So it has to be mixed acidosis. Point T, what happened? Carbon dioxide line moved down. Bicarbonate value increased. So what do you call it as? Mixed
Alkalosis.
alkalosis. So give me an example for mixed acidosis. Mixed means it is both metabolic and respiratory acidosis. So what is a combination? Give me one combination.
Chronic renal failure and COPD.
Good. Chronic renal failure with COPD. So they'll have respiratory and metabolic acidosis. Good. Diabetic ketoacidosis with vomiting or diarrhea. Diabetic ketoacidosis, and give me a respiratory acidosis cause.
COPD.
Again, COPD. Or COPD with diarrhea or vomiting.
Diarrhea.
COPD with diarrhea, because in diarrhea there is metabolic acidosis. COPD is respiratory acidosis. Give me combinations for mixed alkalosis, where the person has both metabolic and respiratory alkalosis. Give me a combination. Metabolic.
High altitude and vomiting.
High altitude and vomiting. Good. Because in vomiting there's metabolic acid alkalosis. They're losing acid, so metabolic alkalosis. And in high altitude there's respiratory alkalosis. So mixed means it's a combination of both metabolic and respiratory, either acidosis or alkalosis. So that is about Davenport diagram. And next let's just do the number problems. I went a bit slow here because this was covered a couple of weeks ago, right? But when it comes to endocrine, let's do it quicker. One thing why I go quick is, this session is also a training for you to think on exams. Exams, you don't have the luxury of spending a lot of time thinking about a question, right? Then you lose time. So that's why doing questions is important. Time yourself. That will train your brain to think quicker. So you are now in endocrine. When I start, I might go a bit fast, but if you want any clarification, ask me. Why I'm going fast is to train you to think a bit quicker, okay? Acid base, I did go a bit slow because we are just did it a couple of weeks ago. So I'll give you some number problems, try to do them. So you have 1, 2, 3, 4, 5 and 6. First step, identify. pH, what's the normal value we will use for comparison? 7.4. Bicarbonate, what's the normal we will use? Just the normal fixed value, 24. Carbon dioxide, what's the normal we will use? 40. So these are the normal values. Then to stage it, for bicarbonate we will use the range, whether to see if it's on the blood buffer line or not. But in the beginning, just use the value 24. Okay, what is it? pH? Acidosis. What has happened to bicarbonate from 24? It's 16. So what has
Decrease.
Carbon dioxide from 40 also has decreased. So both are in the same direction. So it has to be only one type of acidosis. You have to decide. So ask yourself, if it's respiratory acidosis, CO2 should have increased. If it's metabolic, what should have happened to bicarbonate? Decreased. Which of the two has happened?
Metabolic.
Bicarbonate has decreased. So it has to be metabolic acidosis. So now who is going to compensate? Bicarbonate is the problem. So compensation, which value we look for? CO2. Has the CO2 value changed from 40?
Yes.
CO2 is 30. So has the CO2 changed? Yes. But has the pH come back?
No.
So what will you call it as?
Acute?
No.
Partial.
Oh, partially compensated, yes.
Acute means it has to be on this 40. It's not 40. That means
Got
it
it.
has started to change. Correct?
Okay.
The next one, what's the pH? 7.5. So what is it?
Alkalosis.
Alkaline.
Alkaline pH, so it's alkalosis. Then bicarbonate from 24,
Increase.
increased.
Increase.
Carbon dioxide has remained normal.
No.
So it has to be what? What is it?
Metabolic
It
alkalosis.
has to be metabolic alkalosis, and carbon dioxide has not yet compensated. So what are we talking about?
Huge.
Acute.
Or uncompensated metabolic alkalosis. Third one, pH is 7.1. So that would be
Acidosis.
bicarbonate from 24 has
Decreased.
carbon dioxide from 40.
Increased.
Don't think any more further. What is it?
Next.
They are in both opposite direction. If it's opposite direction, good. It has to be mixed. Whenever you see these in opposite direction, it has to be mixed. Okay. Fourth one, pH is 7.6. So that is alkalosis.
Alkalosis.
Bicarbonate from 24, what has happened?
Decrease.
Carbon dioxide from 40, what has happened?
Decrease.
So you should ask whether it's metabolic alkalosis or respiratory alkalosis. If you cannot think it like in the exam, it's a bit stressful, so write down. So if it was metabolic, what should have happened to bicarbonate?
Decrease.
Alkalosis.
Increase. Oh, increase, sorry.
And if it is respiratory, what should have happened to CO2?
Decrease.
Decrease.
So which has happened?
CO2 decrease.
CO2 decrease.
So it is respiratory alkalosis. Now to stage it, which value will you look for? For respiratory, who takes
Metabolic.
the bicarbonate, right? So now to stage it, you want to see if it's on the blood buffer line or not. So now you will use the range 18 to 28. So is the bicarbonate between 18 to 28?
Yes.
Yes.
Yes. So that means it's on the line. So what will you call it as? Acute or uncompensated. Okay. Fifth one, what is pH?
Acidosis.
Acidosis.
Then bicarbonate from 24 has increased.
Increased.
CO2 from 40 has increased. So which acidosis? If it is metabolic, what should have happened to bicarbonate in acidosis? It should have decreased.
Decrease.
If it's
Decrease.
respiratory, what should have happened to CO2? Increase. So which of the
Increase.
two has happened?
Rest increase.
Respiratory.
Respiratory has increased. So it has to be respiratory acidosis. Now to stage it, which value will you look for? To see if it's on the blood buffer or not.
Bicarbonate.
Carbonate.
So now you use the range. Is it on the blood buffer line 18 to 28?
No.
No.
It has moved, but has the pH come back?
No.
So what is it?
Partially.
Good. Okay. Last one. pH is normal, but carbon dioxide from 40, what has happened to it?
It's increased.
Increased. Bicarbonate from 24 has also
Increased.
so it cannot be normal. Instead, what will we call it as? pH has come back.
Oh, this is
Why so difficult?
Compensated.
Completely
yeah,
compensated.
compensated.
That's it. So completely compensated. What and what? Completely compensated. CO2 has increased. So what should it be? Respiratory,
Respiratory. Acidosis.
acidosis.
Acidosis and metabolic alcohol.
So look at the value. CO2 has increased. So it is completely compensated respiratory acidosis or completely compensated bicarbonate has increased. So what will you call it as? Metabolic alkalosis. So these values will help you to determine. So completely compensated respiratory acidosis or completely compensated metabolic alkalosis. And why are you saying it's completely compensated? Because pH has come back to 7.4. Does that make sense?
Yes.
Okay. Sorry, it looks very shabby, but hopefully you could understand what I'm writing. You could understand you could read it.
Yeah.
Okay.
Yeah, we can.
Okay, thank you. So that concludes acid base. And just before we leave, azotemia I wanted to just cover. So azotemia is acute renal failure where the urea creatinine increases within a short time, within 24 to 48 hours, there's a rapid increase in serum urea and creatinine levels. Okay, so that is acute renal failure, under which you have pre-renal azotemia, renal azotemia, post-renal azotemia. Name is self-explanatory. Pre-renal is before the kidney. So anything which affects renal blood flow. Okay, so give me some causes which affects the renal blood flow. If there's
Hypovolemic shock.
hypovolemic shock, or if the renal artery is stenosed.
Stenosed.
So in renal arterial stenosis, the blood entering the renal system only is less. So what will happen to renin-angiotensin mechanism?
No.
Activated.
Activated. Okay, that's another question which one of your friends discussed yesterday. So if there's renal arterial stenosis, the blood entering the circulation is less. So there's renal ischemic changes which will release renin, and that will activate angiotensin. So renal arterial stenosis can activate your RAS mechanism. Okay. Okay, now let's go back to the pre-renal cause. Now here, since the renal blood flow itself is less, so any of this condition, congestive cardiac failure or whatever, renal blood flow itself is less. So what will happen to the blood entering the glomerular capillaries? Decrease.
Decrease.
So hydrostatic pressure will decrease. Therefore, what will happen to GFR?
Decreases.
Decreases. So if GFR itself is less, what will happen to the filtered load of any solute?
Decrease.
Less.
Less. So amount of sodium entering itself is going to be less. So obviously what will happen to the excretion of sodium, fractional as well
Less.
as urinary sodium excretion, both are going to be less. Fractional is percentage, so it's less than 1%. Because filtered load of sodium itself is less, so obviously excretion is going to decrease. But in this condition, was there any problem with the transporters?
No.
Transporters were fine. So what happened to the urea which got filtered? It went back. So because of that, in pre-renal azotemia, what will happen to the urea creatinine ratio? Some of the urea goes back.
Okay.
So urea is going to increase significantly. So the ratio will be greater than 20:1. ADH can act to some extent, but amount of water is less, of course. So because of that, the urine osmolarity compared to the others is slightly higher, because ADH function to some extent it's working. So urine osmolarity may be in say 500s range, 500 milliosmoles per liter. Okay, that's in pre-renal. Start from the pathology. That will help you to remember all these values. And urine osmolarity will be slightly on the higher side compared to the other two, 500 range. Renal, glomerulonephritis, but I want you to remember acute tubular necrosis. So that will help you remember that the cells are necrosed. So because of that, what will happen to the transporters? They cannot work. There was no problem with GFR. Sodium, urea entered, but they could not get reabsorbed. So what will happen to fractional sodium excretion and urinary sodium levels?
Decrease.
Louder, sorry, what is it?
A decrease.
It's getting filtered. It cannot.
Oh, excretion is more, but the reabsorption is less.
Reabsorption is not happening. So what happens to the excretion?
Increase.
Excretion is greater than 1.
Excretion, fractional is greater than 1%. Urinary sodium will also increase because they are not going back, they are getting excreted. So because of that, even urea cannot go back. So what will happen to the urea creatinine ratio? Do you think it will be very high?
Less than 20:1.
It will be less. Urea creatinine ratio is in the blood. So the urea creatinine ratio, because urea cannot go back, urea ratio will be less. ADH cannot work. So what will happen to the urine osmolarity?
It'll be
Dilute.
Very dilute. Urine will be very dilute. Say in the 100 to 200 range. 100 to 200 milliosmoles per liter range. Post-renal, what's the cause? Anything which affects the outflow of urine. Can be a calculi, stone, benign prostatic hypertrophy, tumor. So start from this first. So if there's an outlet obstruction, which Starling's force is affected first?
Space.
Bowman's space. Good. So remember, I told you this in renal. If the outlet is obstructed, fluid will accumulate here. So hydrostatic in Bowman space is increasing. And because of that, what happens to GFR?
Decreases.
It decreases. So initially what will happen to filtered load is less. So the changes will be exactly like pre-renal. The amount filtering is less, correct? So initially they will have findings like pre-renal. But if there is a calculi or some compression, what will happen to the surrounding blood vessels? They get compressed. So what's a complication of this? It can lead to tubular necrosis. And if the patient has developed tubular necrosis, then what type of changes can you see in the renal? So in these patients, their clinical findings can fluctuate between pre-renal, because initially the hydrostatic in the Bowman's increases, but later because of tubular necrosis, they go in for renal. So their clinical findings can fluctuate between pre-renal and renal based on what's happening. So for that, I have to give you additional information. What am I looking for here? Okay. So at least roughly know these changes, and more about it you learn in math. So that concludes acid-base renal failure. Moving on to endocrine system. Give me hormones which are neurocrine secretions, neuroendocrine hormones. Which are the neuroendocrine hormones? What does neuroendocrine mean?
ADH and
That gets stored in the posterior pituitary.
Neurons are releasing them. They are carried by nerve fibers, which will terminate in another organ. So in this case, what are the two hormones synthesized in the hypothalamus? What are the two nuclei groups of neurons?
Oxytocin, ADH.
Yeah, what's the neuron? Supraoptic
And
and
paraventricular.
And
supraoptic secretes
ADH.
ADH.
paraventricular predominantly oxytocin.
Oxytocin.
But there is research telling that they can contribute to the other hormone as well. So if your question for ADH does not have supraoptic, go for paraventricular. But if you have both, ADH mainly comes from supraoptic. So the nerve endings terminate on the posterior pituitary, where they get stored. There is a center here which regulates the circadian rhythm. Circadian rhythm, for which hormones we covered. Which hormone fluctuates and shows diurnal variation?
Cortisol.
Cortisol. So ACTH and cortisol exhibit a diurnal rhythm, right? Where is the maximum peak secretion happening? When do you need?
8 a.m.
Cortisol, you are most alert in the morning, majority of us, right? So it's around 8 a.m. Its secretions are maximum, and least secretion is seen at midnight. So which was the center in the hypothalamus which regulates this circadian rhythm?
Something.
Suprachiasmatic nucleus.
Chiasmatic. Good. Suprachiasmatic nucleus. So then you give you questions like, there's a researcher who's destroying supraoptic. So if supraoptic is damaged, which hormone is affected?
Cortisol.
ADH. If paraventricular is affected, oxytocin release is
Oxytocin.
affected. If suprachiasmatic nucleus is affected, what gets affected?
Cortisol.
The circadian rhythm, the diurnal variation gets affected. So suprachiasmatic lesions can interfere with the circadian rhythm. Okay, so that's about the examples. Now in menstrual cycle, at about the 14th day, normal cycle is between 1 to 28 days. So how do you calculate period of ovulation? From 28 you have to subtract how much?
14.
14, because corpus luteum, the duration is fixed, it's 14 days lifespan, no? So subtract 14, so ovulation happens on day 14. So to cause ovulation, what do we need? Women.
LH surge.
LH surge. And who's responsible for stimulating this LH surge?
Progesterone.
And estrogen.
First half of the cycle, there's no progesterone. Progesterone comes from here, right? Corpus luteum. First half, it's follicles and Graafian follicle. So just before this 14th day, the Graafian follicles, there's a surge in secretion of estrogen, and this surge will stimulate LH. What is this an example for? What type of feedback?
Positive feedback.
Positive.
Feedback. What will happen to the number of receptors as well?
Increasing.
So that's an example for what? Up regulation.
Upregulation.
Upregulation of receptors. where increased hormone will increase the number of receptors also. So this is an example for positive feedback and upregulation. So why was estrogen suddenly increasing just before the 14th day? Because of pre-ovulatory luteinization. So initially the Graafian follicle have two cells. What are they? Theca cells and the granulosa cells. So in the beginning of the cycle, LH mainly stimulates, has receptors on theca cells. So it mainly stimulates only the theca cell, and granulosa cell is stimulated by FSH. Just before ovulation, the granulosa cells also express LH receptors. So your LH will also stimulate the granulosa cells. So because of the combined stimulus, there is a sudden surge in estradiol. So in the beginning of the cycle, estrogen is just high, it's not too high. So when it's just increasing, it exhibits negative. Only when it increases significantly, that is just before the 14th day, can it exhibit positive feedback. At the end of the cycle, in the second half, progesterone is high. So how will the cycle stop? What does progesterone do to the number of receptors towards the end of the cycle?
Decreases it.
Decreases it. So it causes downregulation. So in the end, the uterus is not supported by estrogen and progesterone. The withdrawal will shed off the lining, and that results in menstrual blood loss. What's the other action? Give me another example for positive feedback in women.
Titration.
Oxytocin.
Increased oxytocin, increasing the secretion as well as the number of receptors. So it would be an example for positive feedback and upregulation. Give me a clinical example for downregulation, where increased hormone decreases the number of receptors.
Insulin.
Diabetes, which type?
2. Type 2 malaria.
Insulin decreases the number of receptors. So insulin by itself can downregulate. What else in these diabetic patients will contribute to downregulation? These individuals are generally, what happens to your body mass index?
Increases.
Obese. So adipose tissue, what does it secrete?
Resistant.
Resistant, which can also contribute to downregulation. If a hormone is secreted like this, what do you call it as?
Pulsatile.
Pulsatile secretion.
Pulsatile means hormone is not high for a long duration. So pulsatile hormones cannot downregulate the receptors. So what's the criteria for downregulation? The hormones should be persistently high to cause downregulation. Okay? So these are some of the examples. So if you give GnRH as a pulsatile infusion and GnRH in a constant manner, as a constant infusion, so what will happen to FSH-LH? So if you give GnRH in a pulsatile manner, can it exhibit downregulation?
No.
No. So what
No.
is going to happen to FSH-LH in males if you're talking testosterone? What will happen?
Okay.
It will keep stimulating it, so it will increase. But when you give a constant infusion, then it will downregulate the receptors. So then what will happen to FSH-LH and testosterone?
Decrease.
It will decrease. So that's another concept. No, I've seen a question where they have asked you this. They're giving something in a pulsatile way or a constant infusion. So pulsatile infusion cannot downregulate. It will increase the hormones. But if you give a constant infusion of GnRH, it can exhibit downregulation. Now in a pregnant lady, say we are talking about hormones like estrogen, thyroid hormones, they both help her during her pregnancy. So these hormone production increases. Comment on what happens to her total hormones, the bound hormone and free hormone. Bound means the hormone which is bound to the binding globulins. Free hormone is the hormone binding to the receptor. So what happens in this lady? Total hormone is a sum of free and bound. So what happened to total thyroid? What happened to it?
Increase.
Increase. What happened to the thyroid hormone binding to the thyroxine binding globulin?
Increase.
Increased. But in the end, what happened to a free hormone?
Stayed normal. It remains normal.
So she is still euthyroid. She does not have symptoms of thyroid excess. And why did this happen? Explain. Start with the condition. She's pregnant, so it has to do with the pregnancy. What is released?
Estrogen.
Estrogen will increase. That will stimulate the liver to secrete what?
Protein binding.
Binding globulin.
Binding globulins. So that kept her bound form high. But even though the bound form is high, it's inactive. So this reached the target tissue. But in the target tissue, what happened to the receptors? They stayed normal. Therefore, what happened to hormone binding to the receptor? Remained normal. So she is still euthyroid. Next, hormone binding to cell membrane receptors. They need what to convey information to inside of the cell?
Receptor.
No, they have the receptors there, second messenger. So give me how cyclic AMP is generated. Hormone binds to receptor. It will activate what?
Alpha second.
Before that, G protein. So what do you mean by activation of G protein? The alpha subunit dissociates with GTP, and this alpha GTP will activate the enzyme which converts ATP to cyclic AMP, and that is adenylyl cyclase. And this cyclic AMP will activate protein kinases, brings about enzymatic actions and physiological effects. For the other second messenger, IP3, we need IP3 and DAG. So where are they derived from? These are the byproducts of membrane phospholipids. Therefore, hormone binds to receptor. The same thing, it activates alpha GTP. But now here the alpha GTP has to generate DAG, right? So it will activate which enzyme?
Protein kinase C.
That is later, but I want the enzyme which breaks down phospholipid. So what do you call the enzyme which breaks down a lipid?
PLC.
Phospholipase C. So once phospholipase C is activated, it will break down membrane phospholipids to diacylglycerol and IP3. Now DAG is responsible for activating protein kinase C, which brings about physiological effects by enzyme activation. But can it act alone? What does DAG require?
Calcium.
So DAG requires calcium to cause this activation. So what's the role of IP3?
Immobilizes calcium.
It provides the calcium from the storage sites. Okay, so it mobilizes calcium from the sarcoplasmic endoplasmic reticulum and provides that calcium for DAG, which leads to activation, enzyme activation. Give me a disease or a toxin which causes persistent stimulation of alpha GTP. It does not allow it to dissociate, thereby causing persistent increase of cyclic AMP.
Cholera toxin.
Cholera toxin. Tetanus is different, inhibitory neurotransmitters, right? This is the cholera toxin. In GIT we did in the end diarrhea. So this toxin can cause persistent activation of alpha GTP. It will not allow GTP to dissociate and degrade. So as long as there is alpha GTP, it keeps activating adenylyl cyclase. Cyclic AMP will increase, and this increase in cyclic AMP will keep the chloride channels on the intestinal cells open, and that leads to secretory diarrhea. Chloride will drag water and sodium, and this is responsible for secretory diarrhea. Okay, which was the other substance in GIT which caused diarrhea, which bound to the receptor and activated G protein? That was VIP. So VIP will act on the receptor, lead to activation of G protein and increase cyclic AMP, which brings about secretory diarrhea. Okay. Give me a disease.
Sorry, what does VIP stand for again? I'm sorry.
Vasoactive intestinal peptide.
Okay.
It's seen in a tumor secreting VIP. It's called as VIPoma, and that is secreted by non-beta cells of the pancreas. Remember, the non-beta cells, they can secrete gastrin, and in a tumor there's a tumor which secretes VIP as well. So vasoactive intestinal peptide. So that will act on this receptor, its receptor, activates G protein persistently, and that's how it leads to cyclic AMP effects. Give you a disease where the alpha S subunit of GTP is defective. Therefore, cyclic AMP levels decrease. What was that disease? Do you remember? The alpha stimulatory subunit is defective. So cyclic AMP cannot be generated. So that hormone could not act. Which hormone are we talking about?
Oh, are you talking about the Albright, PTH?
Good. Albright's hereditary osteodystrophy. Where PTH is not the problem, G protein is the problem. And because the G protein is defective, the cyclic AMP is not generated. The GS, actually this whole G protein is defective, so all this does not happen. So because of that, cyclic AMP will decrease. And to correct that, the PTH level actually increases. So that's why the other name for that is pseudo-hypoparathyroidism. Correct? So that is it. Albright's. Good. So give me hormones using cyclic AMP to act. Which hormones use cyclic AMP as second messenger?
FSH, LH,
So anterior pituitary flat hormones, I asked you to remember. These are actually anterior pituitary hormones, FSH, LH, ACTH, TSH. But A and P here stands for the important hormones quite often asked. What are they?
ADH and PTH.
ADH and PTH. So I expect you to remember these two. Okay. Which hormones use IP3? Since it makes use of calcium, it has to be hormones having a contractile activity. Name some hormones.
Oxytocin and vasopressin.
Oxytocin and vasopressin. So if you look at ADH, its vasopressor effect is by IP3 calcium, but ADH antidiuretic activity on the kidney is via cyclic AMP. That is important. Okay, that's about the second messenger system. Classification of hormones based on chemical nature. All the hormones derived from cholesterol. What do you call them as? Steroids. Give me the hormones.
Estrogen.
Sex hormones. Adrenocortical hormones. D stands for
Vitamin D.
vitamin D. Amino acids are derived, amino acid derivatives are derived from tyrosine.
Tyrosine.
So which hormones were derived from tyrosine?
Epinephrine.
Epinephrine, norepinephrine. That's catecholamines and thyroid. Okay, so whatever does not belong to this will belong to the proteins and polypeptide group. You don't have to memorize them. Just remember these. Whatever does not belong there will belong to the third group. Then, based on location of receptors, receptors can either be on the cell membrane, so they will need second messengers, correct? Or the receptor can be located intracellular. So based on location of receptors, either the cell membrane receptors or intracellular receptors. Intracellular means the hormone has to penetrate the membrane. So what is its property? Solubility.
Lipid soluble.
Lipid soluble. It will need more time. So it has a higher half-life, longer half-life. Hormone binding on cell membrane need not penetrate, right? So these are water soluble and they have a shorter half-life. Now what are the hormones acting on our intracellular receptors?
Steroid hormone.
Steroid and thyroid, or the PET cat. Where PET-CA, this stands for steroid hormones, T stands for thyroid. So what are the steroid hormones? Sex hormones, progesterone,
Estrogen, testosterone, cortisol, and aldosterone.
so they are all the sex hormones. Steroid hormones, progesterone, estrogen, testosterone, cortisol, aldosterone, and thyroid hormones. Cell membrane are classified based on second messengers. So you already told me cyclic AMP is ADH, PTH, FSH, LH, ACTH, TSH. So anterior pituitary flat hormones. IP3 calcium also you told me with contractile activity, vasopressin and oxytocin. Tyrosine kinase, which were the hormones?
PIG, prolactin, insulin, and growth hormone.
So prolactin and growth hormone are similar in structure. They use the same second messenger and insulin. What's the last one? Cyclic GMP. These are the non-endocrine hormones. So what were the two important non-endocrine hormones we covered?
ANP and NO.
ANP and nitric oxide. What's the other name for nitric oxide?
EDRF.
Endothelial derived relaxing factor. It's the same. Okay. So that's why, in high altitude, what has happened to the blood vessels? Because of hypoxia, what can happen to the pulmonary blood vessels?
Sure.
They constrict, correct? So hypoxia causes pulmonary constriction. So if somebody goes up too quickly, the pulmonary venous constriction is more immediate. Arterial constriction will take a while, but if you go up too quickly, there's venous constriction which causes blood to accumulate in the capillary, which will cause leakage of fluid, high altitude pulmonary edema. So what was causing this high altitude pulmonary edema? Pulmonary venous constriction. So in pharm later they will talk about drugs. So how can you treat? You can give drugs which will prolong nitric oxide. So if it has to prolong nitric oxide, what should it do to cyclic GMP levels? Increase. Okay, so there are those drugs, later you will learn. These drugs will inhibit the enzymes which break down cyclic GMP. So in other words, they increase cyclic GMP lifespan. It will increase nitric oxide activity, and nitric oxide will cause vasodilation, and once the constriction is relieved, edema will be corrected. About insulin, it uses tyrosine kinase. But what's the unique property of insulin? Where is the tyrosine kinase located? So if you look at insulin, we'll cover the action of insulin. The receptor has 2 alpha and 2 beta subunits, correct? They are all joined by disulfide bridges. They are all connected by the disulfide bridges. Okay, everything is connected. So the unique property of insulin is it will bind to this alpha subunit, and that will cause a structural change which will activate the beta subunit, and the second messenger tyrosine kinase is embedded in the receptor. So for insulin, the tyrosine kinase is embedded in the beta subunit of the receptor itself. So that's why it's an example for a receptor embedded mechanism, second messenger system. So once the conformational changes happen, tyrosine kinase gets released, and that will phosphorylate a group of enzymes. What are they? Insulin receptor substrate group 1, type 1. That ultimately will activate the final enzyme required for inserting GLUT4. So what was the final enzyme required for insertion of GLUT4? Pi3
PI3
kinase. So that will insert the GLUT4. Which activity can stimulate Pi3 kinase independently? Exercise. So that's why in diabetics, if they exercise, Pi3 is activated more, so GLUT4 can increase, and that helps in cellular uptake of glucose. Thereby, what will it do to the blood glucose levels? Decrease. Okay, so exercise is good for diabetics because of this. And this is one thing you have to remember. For insulin action, tyrosine kinase is located in the beta subunit of the insulin receptor. That's about the introductory topics. We'll take a break. I'll stop the recording and I'll start another recording to make it like 2 hours slot. Okay, and when you come back, we'll do the rest.
Thank you.
Yes? Did somebody ask you?
What time will come back?
Sorry, 10:10. The regular, take your regular break.
Oh.
Okay, I'll start again at 10:10. Sorry, I forgot to tell that. Yeah, take a longer break now. Thanks.
Thank you.
Dr. Prajna, can I ask a quick question?
Sure, tell me.
Regarding exercise. So exercise causes the insertion of GLUT4 because it stimulates PI3.
Correct. So exercise, no?
Okay.
Independent of insulin, it can stimulate Pi3 activity to some extent. Of course, not as much as insulin, but to some extent there's a milder stimulus. So this Pi3 will act more. So GLUT4 will be more.
Okay.
So that will
Thank
help in
you.
glucose uptake and reducing blood sugar. Yes.
Got it. Thank you.
You know what, guys? You can remain here. I'll just log off the system once to see if I can correct the pen, and I will come back again. Okay, thank you.
Okay, thank you. Let me know if you need anything.
Now I have to assign a host and leave. So can I make, or should I end the meeting for all? But then you'll have to re-log in. So instead, I will maybe assign you as the host and give me the rights back when I get back. Okay.
Okay, sounds good.